The efficacy cliff is every surgeon's dilemma. When the efficacy of MIGS plateaus, higher risk bleb-forming procedures have historically been the only remaining option. But what if you could delay the need for a bleb-forming procedure, or surgically assess a complementary natural outflow path and add another surgical intervention to your toolkit? With Ophthalmic Innovation, now you can. Unlock a new surgical pathway to enhance natural outflow with AlloFlow uveal dual biospacers and the AlloCert UVO delivery platform. Learn more at MMed.com.
This is Ike Ahmed.
And I'm Arsham Shaybani.
And we want to welcome you to GT the Podcast.
We're bringing this to you together with BMC and Glaucoma Today,
to offer audible insights into current topics in glaucoma care.
Presented by the authors of our latest, most read GT articles.
Check it out.
Welcome to GT the Podcast. In this episode, Dr. Chelvin Singh recaps her article, The Paul Glaucoma Implant, which was featured in the November-December issue of Glaucoma Today. The Paul Glaucoma Implant from Advanced Ophthalmic Innovations is a glaucoma drainage device designed to fulfill the unmet need for a tube shunt with greater efficacy but a lower risk of hypotony. The Paul Glaucoma Implant, which is commercially available in parts of Europe and Asia, has a large end plate surface area and a smaller tube lumen, features that may improve the safety and efficacy of tube shunt surgery. In her article, Dr. Singh reviews the characteristics of the device, surgical technique, postoperative management, and clinical data. For more on this, listen now to Dr. Singh.
Glaucoma drainage devices, also known as tube shunts, are most commonly used in the context of refractory and medically uncontrolled glaucoma. The two most frequently used tube shunts are the unmet glaucoma valve and the bar-valve glaucoma implant. Both were introduced in the 1990s and have undergone minimal to no design changes in more than 20 years. Comparative studies have found that the bar-valve glaucoma implant has a lower failure rate but a significantly higher risk of hypotony than the unmet glaucoma valve. The superior efficacy of the bar-valve glaucoma implant is thought to be related to its larger end plate surface area of 350 square millimeters compared with the unmet glaucoma valve of 184 square millimeters. When deciding between an unmet glaucoma valve and a bar-valve glaucoma implant, surgeons must choose between the higher safety profile of the former and the superior efficacy of the latter. The Paul Glaucoma Implant from Advanced Ophthalmic Innovations was designed to fulfill the unmet need for a tube shunt with greater efficacy but a lower risk of hypotony than the available options. The Paul Glaucoma Implant was developed by surgeons at the National University Hospital in Singapore and Moorfields Eye Hospital in London. It has CE mark approval and is commercially available in parts of Europe and Asia. Like the unmet glaucoma valve and bar-valve glaucoma implant, the Paul Glaucoma Implant is made of medical-grade silicone. It is a non-valved tube implant with an end plate surface area similar to that of the bar-valve glaucoma implant and larger than that of the unmet glaucoma valve. A unique feature of the Paul Glaucoma Implant is its smaller tube, which has an internal diameter of 127 micrometers. This is significantly smaller than those of the bar-valve glaucoma implant and unmet glaucoma valve, which have internal tube diameter of 300 micrometers. The smaller lumen size may reduce the risk of persistent hypotony. The tube also occupies less space in the anterior chamber, theoretically minimizing the risk of endothelial cell loss, although more studies are required to support this claim. Another distinguishing feature of the Paul Glaucoma Implant is its pliability, which allows for flexibility in placement of the plate under the muscles, especially in complex cases of eyes with a history of filtration surgery. The surgical procedure to implant a Paul glaucoma implant should feel familiar to glaucoma surgeons because it follows the standard principles of tube shunt surgery. Various techniques for implanting non-valve tube shunts are in use, but in my experience, inserting an intraluminal stent, usually a 6-0 polypropylene suture, into the Paul glaucoma implant tube lumen provides the most predictable outcomes. The stent does not completely occlude the tube lumen and allows early aqueous flow through it, thus avoiding early postoperative IOP spikes. The technique also provides sufficient flow resistance to minimize the risk of early hypotony. If the patient's IOP subsequently rises, the stent can be easily removed at the slit lamp, increasing aqueous flow through the tube. In this way, surgeons can tailor postoperative management to each patient's response. With this surgical technique, I have found the postoperative course of the Paul glaucoma implant to be more straightforward than that of the other tube shunts, with fewer early postoperative complications that necessitate repeat surgery. The use of adjunctive mitomycin C and anti-VEGF drugs in tube shunt surgery for primary open-angle glaucoma is not well established. These agents may have a role in patients who scar aggressively and in those with advanced glaucoma who require a lower target IOP. Further research is warranted. All clinical studies conducted to date have reported that the Paul glaucoma implant is effective for decreasing IOP and reducing patients' need for IOP-lowering medications. These results have been sustained for at least 3 years in patients with primary open-angle glaucoma, and 5-year data should be available soon. Tan et al. Reported that at 3 years after Paul glaucoma implantation, mean IOP was 14.9 mm of mercury compared with 32.6 mm of mercury at baseline, with a reduction in glaucoma medications from 3.13 at baseline to 0.17 at 3 years. The Paul glaucoma implant has also been shown to be effective in eyes with uveitic, neovascular, and pediatric glaucoma, as well as in combination with cataract surgeries. Studies directly comparing the Paul glaucoma implant with other tube shunts are limited. Bertilud et al. Reported that the Paul glaucoma implant and Barvelt glaucoma implant have similar success rates of 91% and 89% respectively. The Paul glaucoma implant demonstrated superior early postoperative IOP control with less early postoperative hypotony than the Barvelt glaucoma implant, likely because of its smaller tube diameter. Other studies comparing the Paul glaucoma implant to the MMed glaucoma valve found potentially reduced complications in the Paul glaucoma implant group, although these studies are limited by their small sample sizes. A systematic review of 18 studies with moderate to good quality evidence reported that the Paul glaucoma implant consistently demonstrated significant IOP reduction across various studies and glaucoma subtypes. Mean IOP reductions ranged from 14.8 to 19.1 mm of mercury, with qualified success rates of up to 93.2% and potentially fewer early complications compared with other glaucoma drainage devices. Less than 6 years since its introduction in the United Kingdom, the Paul glaucoma implant is used in more than 60 countries and is becoming a valued tool for many glaucoma surgeons. Its large end-plate surface area, combined with a smaller tube lumen than those of the Barvelt glaucoma implant and MMed glaucoma valve, may give the Paul glaucoma implant superior efficacy and reduces the risk of complications, especially hypotony. More prospective, comparative, randomized studies are required.
Thank you for tuning into this episode of GT the Podcast. If you have any feedback or topic suggestions, find us on Instagram, LinkedIn, Facebook, or Twitter. And stay tuned for more hot topics in glaucoma care on GT the Podcast.